Okay, hi guys. So this is just going to be like a brief 15 or 20-minute addendum to the bipolar disorder spectrum and suicide prevention lecture. So this is still mood disorders lecture 3. So in the last couple minutes of this lecture, I'm just going to briefly talk about suicide prevention, which does fit in with the theme of mood disorders because a majority of people who complete suicide or who attempt suicide do have symptoms of depression. However, because depression is so common, the vast majority of people who have depression never attempt or complete suicide. So although we're going to be talking about it in the context of mood disorders, we're actually going to be talking about more specific and more sort of sensitive and predictive risk factors for attempting or completing suicide. This slide shows the Golden Gate Bridge because in your further readings section, there are a couple articles about people who attempt suicide on the Golden Gate Bridge and interviews of people who have survived non-lethal suicide attempts. The interesting thing that all 26 of these people have in common, there's not very many of them because although suicide attempts on the Golden Gate Bridge are really common, the majority result in death. But the people who survived these attempts have all said that as soon as they jumped, they basically immediately regretted what they'd done. And that kind of illustrates the point that suicide attempts are kind of one point in time, and they are preventable if you can identify some of the proximal risk factors, which is what this lecture is going to focus on. So some terminology. We've talked already about suicidal ideation, which is thinking about death or wanting to die. When we make a distinction between ideation and intent, what that distinction means is that when someone has ideation, they might be really preoccupied with death, thinking a lot about death, even thinking a lot about suicide, but they don't have the actual desire to do something to take their own life. So when ideation moves to intent, that's when it moves from just wanting to die or thinking about death a lot to wanting to do something themselves to cause their own death. The next stage of risk from intent is having a plan. So a plan is basically obviously what it sounds like, but specifically when assessing for suicide risk, one of the most important things to ask about someone's plan is the means that they plan to use to take their own life. An attempt refers to someone who tried to die but was unsuccessful, and unsuccessful is not a great word for that because obviously surviving a suicide attempt is really successful, but they didn't complete their goal of taking their own life. And that can be because they were saved through medical intervention, or the means that they used to try to take their own life were not completely lethal. So a completed suicide is the term for a lethal attempt. And we say completed suicide rather than committed suicide because suicide isn't a crime. It's a severe symptom of mental illness, or sometimes it's not a symptom of mental illness, but it's just a bad impulsive decision. Okay, so on average in the United States right now, suicide is the 10th leading cause of death for the whole population, but that obscures the fact that it's actually the second leading cause of death for young people. So from ages 10 to 34, suicide is the second leading cause of death after unintentional injury. And experts think that the suicide rate for this age group might actually be higher because a lot of unintentional injuries, so-called, may actually have been completed suicides. For example, people who drive recklessly or sort of intentionally cause a car accident, if the suicidal intent isn't recognized in that, their death may be reported as an unintentional injury when really it was a suicide. What these statistics in the figure show is that since the early 2000s, the rate of suicide has gone up for both men and women, a little bit more sharply for men. It also shows that men complete suicide more often. What it doesn't show is that women actually are the demographic that make more suicide attempts. And the reason that men complete suicide more often is because men tend to use more lethal means when they attempt suicide. So women are more likely to use means that take longer or that are not as lethal so they can be saved. That doesn't mean that those attempts aren't like quote unquote serious. It just means that, as we'll talk about in a couple slides, there may be gender differences in some of the proximal suicide risk factors that relate to comfort with using lethal means. Oh, and then just a caveat. So suicide is really rare. In the last lecture, or in the earlier part of this lecture, I talked about how bipolar spectrum disorders are the most rare disorders we've talked about so far, with a prevalence of around 3% in the population. But suicide is super rare. So 22 people in 100,000 comes to a prevalence of 0.0002%, so way less than 1% of the population, obviously, completes suicide. Attempts are more common, and ideation is much more common, but ideation on its own is not a great predictor of completed or attempted suicide. So what are the biggest risk factors? As I said, having a plan is a serious risk factor. So working with a patient who has suicidal ideation, I would be much more concerned and worried about them if, in addition to suicidal ideation and intent, they had a specific plan for how they would take their life. An even more significant risk factor could be previous attempts. So basically, one of the best predictors of whether someone is going to attempt suicide is if they've done it before. And that points to the fact that we're not that good at predicting who's going to attempt. So psychologists and psychiatrists aren't great at predicting that first attempt, but when someone has already made an attempt, we worry about them more when they have suicidal ideation. And then the last and probably most significant, because it's the one that we can intervene on the most, is access to lethal means. And we're going to have a guest lecture from Dr. Smith later in this little segment, where he, I think in that section, talks about treating people who have suicidal ideation and suicidal intent and plans by limiting their access to lethal means. So other risk factors that are way less proximal because they're just so much more common are mood disorders, substance use. A lot of suicide attempts take place when someone is intoxicated, especially with alcohol, because that lowers inhibitions and it can make people less fearful. And being fearful of death is a major protective factor against suicide. So alcohol reduces that anxiety. In the context of mood disorders especially, insomnia is a major risk factor for suicide. Separately from mood disorders though, impulsivity, not separately in that someone with a mood disorder who's also impulsive and has suicidal ideation and intent is at high risk, but impulsivity on its own is also a risk factor. And then the last risk factor that is a little bit less proximal, but still important, is a concept known as capability for suicide, and we'll talk about what that means. Okay. So, as I said, it's very difficult to predict suicidal behavior. So, suicidal ideation, so thinking about death and maybe even thinking about suicide, is really, really common in people with mood disorders. It's more common in people with bipolar 1 and 2, which, as we said earlier in this lecture, is probably because the depression symptoms that people experience in bipolar disorder tends to be more severe and intense. But even with unipolar major depression, 60% of people who are having a mood episode, a major depressive episode, have suicidal ideation. And as Dr. Lasse said in an earlier guest lecture, people tend to have recurrent episodes of major depression, and the symptoms of depression that they have can vary from episode to episode. So the lifetime prevalence of suicidal ideation in major depressive disorder is higher because 60% is just a snapshot in time with one mood episode. So that 40% who didn't have suicidal ideation during that mood episode could still have suicidal ideation during a future mood episode. So what this is meant to illustrate is that ideation is common. Major depressive disorder affects 50% of the population, and 60% of those people or more will have suicidal ideation. And even though bipolar disorder is more rare, suicidal ideation is more common in that population. And because the severity of all symptoms is higher, the suicidal ideation in that population could be more intense. So compared to ideation, attempts are pretty rare, very rare. And compared to attempts, completed suicides are even more rare. And that is true even among people with psychopathology. So one thing that this figure is showing is that of people who had serious thoughts about suicide, so this would be people with intent, not just ideation, around like 3.5 to 4% of them about 3% of them had plans. So, or sorry, 30% of them had plans. So the majority of people who have serious ideation and intent don't have plans. A majority of people who have plans never make an attempt, but it's a bigger percentage. So about a third of people who have plans at some point attempt. And the interesting thing that this figure is showing, the kind of scary thing that it's showing, is that there's actually a segment of people who have ideation but no plans, or deny having plans but still make an attempt. And what this is probably reflecting is impulsive attempts. And impulsive attempts are more likely to happen under the influence of substances, or during a manic episode, or in someone who just has a really impulsive personality. So how do we predict from the population of people who have ideation and intent, and even from the population of people who have plans, who will actually go on to attempt or complete suicide? The most serious, or one of the most serious proximal risk factors in the context of access to lethal means is capability for suicide. And basically what that means is being ready and unafraid to die. So the majority of people who have suicidal ideation would never do anything to take their own life because, as Dr. Smith says in his full guest lecture, committing suicide goes against millennia. And sorry, I just slipped and said committing suicide because that's a colloquial term, but it is completing suicide. Attempting or completing suicide goes against millennia of evolution. In every other context where we've talked about evolution, it's been about how our behaviors are selected by the environment to promote survival. So suicidal behavior is very selected against because our ancestors who completed suicide were obviously less successful at passing on their genes. So in order to attempt and complete suicide, you have to overcome the very natural fear and aversion that we have to hurting ourselves and to death. And that in the field that's known as capability for suicide. So we make a distinction between two concepts, acquired capability and trait level capability. Acquired capability was this theory that's kind of falling out of fashion right now as we gather evidence that it might not be super accurate. But the theory was that there are some people who, because of their lifestyle, because of often their occupation, become sort of desensitized to fear and pain and violence. So they become more capable of suicide because they become less afraid of violence, pain, and death. What seems to actually be more predictive is the idea of a stable trait level capability. So this theory is that some people are just sort of naturally more fearless, naturally less sensitive to pain, and naturally less averse to violence. And the reason that our initial theory was that there's such a thing as an acquired capability is that people who have a trait level capability tend to self-select into some of the fields that we used to think led to acquired capability. So these fields are things like being a cop, being a firefighter, being a paramedic, being a soldier, or as we'll talk about in another slide, being a physician or a veterinarian. There is more evidence that there's trait level capability than that acquired capability happens. One interesting thing is that in genome-wide association studies, which as we talked about are studies where researchers look at someone's entire genome and compare the entire genome of people with one trait to the entire genome of people without that trait to see what genes are more common in people with the trait. So these studies have found that there's overlapping genetic diathesis, so genetic vulnerability, for depression and suicidal ideation, which makes sense, again, because suicidal ideation is part of depression. However, the risk factors for suicide attempts, so suicidal behavior, is actually distinct from the diathesis for suicidal ideation and depression. And what this is saying is that people who attempt and complete suicide, many of them do have depression and suicidal ideation, but that alone isn't enough to lead to really high risk of completing suicide. And what we think that additional genetic diathesis for suicidal behavior has to do with this trait level capability. So fearlessness, pain tolerance, willingness to die. The concept of capability comes from a larger theory known as the interpersonal theory of suicide. So capability for suicide alone is absolutely not enough to predict someone's eventual suicide attempts or death by suicide. Just because someone is capable doesn't mean that they would have any desire to take their own life. So the rest of the interpersonal theory of suicide attempts to explain who is likely to have suicidal desire or suicidal intent. So in people with major depressive disorder, the symptom of hopelessness, so feeling just hopeless about things ever getting better in the future, is a stronger predictor of suicide than other depression symptoms, except for insomnia, which is also a strong predictor. But insomnia is very strongly tied to hopelessness. So hopelessness seems to be one of the strongest factors that predicts suicidal intent. And the interpersonal theory of suicide posits that hopelessness comes from two things that have to do with our social roles and social interactions: thwarted belongingness and perceived burdensomeness. So thwarted belongingness has to do with not feeling like you're part of a group or a family, not having a sense of camaraderie or social support from other people, despite wanting it. So not everybody necessarily wants belongingness to the same degree. So someone who really wants it and really doesn't have it is more at risk for hopelessness. And then the other risk factor for hopelessness is perceived burdensomeness. So thinking that not only do you not have support and love from people, but you're also a burden to the people around you. So these two beliefs or experiences feed into hopelessness, which predicts suicidal ideation and intent. But in order for someone to actually go on to attempt or complete suicide, their intent has to be accompanied by capability, and not everyone has that capability. So the interpersonal theory of suicide is really good at predicting, or not really good, but better than looking at things like just depression or just bipolar disorder or just substance abuse or just impulsive temperament. These thoughts, I'm alone, I'm a burden, are better predictors of suicidal ideation. And really the best predictor of attempted or completed suicide is capability. So not being afraid to die. So this is just a first person perspective that I just grabbed from YouTube of someone sort of expressing thwarted belongingness and perceived burdensomeness. So this person says, I'm 36, isolated, have asked for help everywhere, including friends, family, and the suicide hotline. Nothing came to fruition. So they're reaching out and looking for support, and they're perceiving that they're not getting it. Everyone I meet seems to be offended that I'm alive at all, so they feel like a burden. I only wish I could oblige my offensive existence and leave this world. I can only continue to apologize for my presence on earth for the time being. So this person is expressing thwarted belongingness, perceived burdensomeness, hopelessness, and suicidal desire. But what we don't know about them is whether they have the capability for suicide, and that, along with access to lethal means, is the strongest predictor of an attempt. So this is a little summary of kind of the debate between whether acquired capability or trait capability is a stronger predictor of capability for suicide. So the concept of acquired capability, like I said, came from observations that there are some professions that have a really high rate of suicide. And some of these are ones that would make sense because they're also populations that are exposed to a lot of trauma. And as we'll talk about 2 lectures from now, PTSD is also a risk factor for suicide and depression. But soldiers, firefighters, and police have higher rates of attempted and completed suicide, especially completed suicide, than the rest of the population. But what's interesting is that doctors and veterinarians do too. So people have tried to use the acquired capability model to explain how doctors and veterinarians could have such high rates of suicide. And experiences that they have in common with soldiers, firefighters, and police are that to varying degrees, doctors and all veterinarians have exposure to seeing humans or animals in pain and to death. Veterinarians and some doctors have a lot of exposure to blood and gore and have kind of seen the internal workings of the human body. And so that could theoretically desensitize them to the idea of doing something to like hurt or damage their own body. But what actually seems to explain why doctors and veterinarians have similar suicide rates to soldiers and firefighters and police is actually common personality traits. So people who go into these fields tend to be very determined and have a lot of grit and perseverance. It takes a lot to get into medical school and actually even more to get into veterinary school because there's fewer of them. So people have to work really hard and be really willing to delay gratification and to put aside making themselves happy in favor of working towards a goal. People who go into the medical field and veterinary fields also tend to be sensation seekers and risk takers. Not everybody wants to have responsibility for the life of another human or animal, and people who do want that, like sort of excitement and adrenaline rush, are more likely to go into those fields. And you may be wondering, is there variability in the type of medical doctor who's most at risk for suicide? Yes, emergency room doctors and surgeons are at highest risk. And again, could be because those types of doctors see more blood and gore and more death. It could also be because of the personality that it takes to go into those medical specialties, being really comfortable with taking risks. So I want to highlight, though, that the biggest thing all of these professions have in common, and really one of the best variables that explains why they have high rates of suicide, is that all of these professions have access to lethal means. So soldiers and police are really comfortable with firearms, guns. Guns are basically the most lethal means that people have for suicide. But doctors and veterinarians have access to drugs that they can overdose on, and they have the medical knowledge to know how to make that lethal. So the real common thread here seems to be personality traits and temperament, access to lethal means, and maybe also traumatization and exposure to death. So another question that comes up a lot with suicide is whether this idea of suicide contagion is real. So you guys may remember some of the controversy over the Netflix show 13 Reasons Why. It's a show that kind of romanticizes suicide and sort of presents it as like the ultimate way of getting back at people who were mean to you and making everyone realize after your death how great you actually were, which is not a great message, because that is actually not what suicide survivors tend to experience. They tend to experience depression, complicated grief, suicidal ideation themselves. So it's not a great portrayal of suicide, but there was a lot of concern that it would lead to increases in suicidal ideation and behavior. So do works of fiction that portray suicide lead to increased suicidal ideation? It seems like no. After 50 Shades of Grey, that did influence people's behavior. After 13 Reasons Why was released, oops. Oh, I guess I don't have figures for that. I'm sorry. But after 13 Reasons Why was released, there were increases in teenagers' calls to suicide hotlines, but not increases in actual suicide attempts or suicidal behavior. So it seems like, at most, fiction with themes about suicide or fictional depictions and even glorification of suicide seems to increase ideation, but doesn't increase attempts. Media reports of famous people's completed suicides, though, may actually lead to suicide contagion. So research documented a 10% increase in completed suicides after Robin Williams' death by suicide. And most importantly, though, for the theory, they also documented an increase in suicides using the means that Robin Williams used to complete suicide. So the theory with media reports of suicide is that they might increase ideation in the same way that fiction with suicide themes does, but because they're reporting on completed suicides, they're also sort of telling people what means are most lethal. So they could be giving people greater access to lethal means by giving them kind of ideas about the most lethal way to attempt suicide. So because lethality of means plus having intent and a plan plus acquired capability is like the biggest proximal risk factor, any documented suicide contagions in the media are probably the result of an increase in lethal attempts. But there's no evidence that suggests that people who were not at risk of suicide before become suicidal when they're exposed to suicide themes in the media. It really has to do with people who are already vulnerable, already with a lot of intent, maybe with a plan, maybe with capability, learning more about access to means, or being prompted to complete suicide at a time when maybe they wouldn't otherwise, but they had all the vulnerabilities before they were exposed to this media. So what this is showing, this is the suicide spike after Robin Williams' death. He died in 2014 in August or late July, or I guess maybe early July. But anyway, what this is documenting is a spike after Robin Williams' death that went above the predicted suicide rates for previous years. So this is the 10% increase in suicide after Robin Williams' death. This is a study looking at not attempts, but ideation. So this study looked at calls to suicide hotlines. And the dotted lines are, this is the release of 13 Reasons Why. This is Kate Spade's death by suicide, and this is Anthony Bourdain's death by suicide. And what this is showing is that celebrity suicides or media reports about suicide lead to more increases in ideation than fictional portrayals of suicide. And again, this could be because people who are already at risk for suicide, it's not that it gives anybody the idea, but it might give them more specific ideas about how to do it. Okay, so I wanted to just play this video for you guys because this gives a slightly different take on why suicide rates might be increasing in the United States. But in the discussion board, I'm going to ask you to try to make the connection between this economic theory of increasing suicide rates and the interpersonal model of suicide rates. So as you're watching this, think about themes of thwarted belongingness and perceived burdensomeness in the context of economic changes.
Professors Deaton and Case are on a mission to solve a mystery. What's behind the decades-long rise in suicide rates in America? And what does it say about our country?
In every state, in primate rates and deaths from suicide went up between 1999 and 2016. But we think it's a real sign that something is not right.
The professors note that the suicide rate among middle-aged African Americans isn't on the rise, and it's far lower than that of whites.
Even though whites are wealthier, within an African American community, you feel you are part of the community.
Suicides are striking especially hard in a most unlikely area, one where the myth of America was made.
There's a suicide belt in America right up the road.
Arizona, New Mexico, all the way up to
Alaska.
and then if you actually went further into
Is there really a thing, a suicide belt?
That's what they call it. They call it Matthew Trevor suicide rate high. Looks like the Rocky Mountain.
Are we talking about despair caused by economic hardship, or is it something in the spirit of America?
I think economics trigger some of these things, but in the end, it's a failure of spiritual, social life that drives people to suicide.
Is it reasonable to think that if some of these people had more money, that they wouldn't fall into the pits of despair?
I don't think anyone minds, but if they had more money, they'd be better off, right? Before the time is up. But you can't link these deaths down.
If you take a look at the data from the Great Recession, you see what they mean. Even though the economy tanked and Americans lost their savings, it didn't significantly move the suicidal trend line.
You use the term deaths of despair. Did you guys coin that?
Yeah.
The addiction thing is so close to suicide. Some of the opioid doctors talk about a lost generation.
One of the things that intrigues the researchers is that it seems to be a North American phenomenon.
This is where the comparison to Europe is very important, because you don't really see deaths of despair.
Though in Southern Europe, you do see really high unemployment, particularly for young people.
We're not talking about unemployment here. It's much more to do with these, things that you would correlate with the spiritual crisis.
The Europeans are not killing themselves the way that the Americans are. They've lost jobs. technological changes come to Europe. So one of the places our research will go next is what are the big differences between the Europeans and the Americans, that it's helping the Europeans keep body and soul together.
Decision Case offers some theories. One, the breakdown of families.
The things that make people want to kill themselves and lose the meaning of life are to do with things like your marriage has never worked out. You don't know your kids anymore.
Social bonds deteriorating. Is that what we're talking about?
Another theory, Americans making a religious migration to churches that Case thinks are changing the way faith connects in the community.
And you said something really provocative on this. You've singled out the evangelical church.
That is a church that more people are identifying with, and it's a church which encourages my personal relationship with my Savior. But it's a very individual experience. Whereas the mainline Protestant churches or the Catholic Church would be a part of a community.
We've nothing against the evangelical church, and we're certainly not correlating evangelicals with us. We don't have data for that. But one of the things you might think, if a community is coming apart, is you see less religious observance, and you do not.
But there is one correlation they find in the numbers.
All this bad stuff, by and large, is happening to people who don't have a BA. And people who do have a BA are largely exempt from this. The economy is no longer offering a good life to people without a university degree.
People in the US that only have a high school diploma are more than twice as likely to kill themselves as those who hold a college degree. Today, fewer than a third of Americans ultimately earn a bachelor's degree before reaching the age of 29.
We can only generate good lives for an elite that's about a third of the population. Then we have a real problem.
The real problem, as Deaton and Case see it, is that deaths of despair are an indicator.
So, I would go as far as to say if we can't fix this, it is a crisis of capitalism. It doesn't seem to be working for people who are not very well educated. Up until the Second World War. The dominant intellectual views then was that capitalism was sort of broken.
Little man, not now.
A lot of people who were flirting with communism or socialism in one form or another. And what seemed to happen after the Second World War is that it started delivering for more or less everybody. And so you got this long period from 1945 through the early 70s when all boats rose together. Working class people, people who had a college degree, who entered the labor market around 1970, had a great world. That was a world in which you could belong to a union. There was a fabric of working class life which looked like it was going to go on forever. And that world has been sort of coming apart since 1970. Median wages in real terms have been pretty stagnant for 50 years.
The professors think conditions are ripe in America for one of two things to happen. One, a resurgent left declaring war on laissez-faire economics.
Capitalism in America is much more anti-worker than it is in Europe. Income tax rates are not very different from what they are here. But in Europe, there's a value-added tax that generates a huge amount of revenue, which is used to maintain an elaborate social safety net. We don't have that here.
We've produced the Bill Gateses, the Mark Zuckerbergs, the Steve Jobses. They come from America, not from Europe. Some of the greatest minds on this planet have emerged from this society.
Well, a lot of them are immigrants. Something like half of the Fortune 500 companies were started by immigrants. The year I got the Nobel Prize, there were 4 Americans. 3 of us were immigrants. Do we have a free society? We don't look after each other. In the end, it's rough and tumble. A lot of people fall in through the cracks, but on average, we do well. But the question is on average we do well okay if it's only the top third? If it's only the people with BA? In the end, you want a world where people don't have to go to college, right?
The other possibility, with inequality reaching such a high level, they say it may be the fabric of our society that could be the next casualty?
You know, when you see a society's life expectancy begin to tip over for like 3 years in a row, which has been for whites, 2 years for the whole population. The only time that's happened before was because of smoking. So this is, you know, that does suggest that something really bad is going on under the surface.
Canary in a coal mine kind of situation?
Yes, exactly. And that's very worrying. And you know, the world is a much better place, but it's a very fragile place. What happens if, say, the stock market fell by 50% again? You could have some constitutional crisis. You could have a lot of things like that that go together. North Korea is the most obvious thing. Put a couple of those things together, the world would not look like such a happy place.
These acclaimed Princeton professors think the American ideal of self-reliance is, due to changes in the economy, becoming outdated. Is the isolation and despair being experienced by so many people in this country, less educated whites in particular, pushing us towards some sort of crisis? What do you think? We look forward to reading your comments.
Okay, so that video was actually made before the coronavirus pandemic happened. And you guys may have seen the news. There was a recent study in JAMA. I'm looking at it now on my phone because I wanted to actually look at the real prevalence. But this study showed that since the beginning of the coronavirus pandemic, when people became even more isolated than they were before, and also when a lot of people experienced more economic hardships than they've ever experienced before, the prevalence of depression in the United States has tripled since February or March. So let's see. So depression symptom prevalence was higher in every category, every demographic category during COVID-19 compared with before. So 24%, 25% of people had mild depression compared to 16% before the coronavirus, 15% moderate compared to 6% before the coronavirus, 8% moderately severe compared to 2.1%, and 5% very severe versus 0.07% after the coronavirus. So some of the predictors of developing depression during the coronavirus pandemic were having lower household income, having less than $5,000 in savings, which describes like 60% of America, and exposure to more stressors. So that study that just came out between recording the last lecture and this lecture really illustrates the impact that the economy via stress, but as these professors are also arguing, maybe via social isolation and alienation, has on depression and then downstream on suicide. Okay, so after all that, how do we, as psychologists, try to prevent people from attempting and completing suicide? So this is an excerpt from this week's guest lecture by Phil Smith, who is a professor in our department. His research focuses on suicide prevention and training professionals to prevent suicide in their patients. So how do clinicians treat patients who are at high risk of suicide because they have thwarted belongingness, perceived burdensomeness, suicidal intent, and acquired capability or trait capability? How do we prevent them from attempting and completing suicide?
You think about working with someone who might be at risk for suicide. Of course, the most important thing is to ask them, are you thinking about suicide? And in the presence of suicidal thinking, and in particular suicidal thinking that is not just about wondering about what it would be like to be dead or even wants to be dead, but the resolution towards planning and preparation for suicide and specificity about how someone plans and prepares for suicide is particularly alarming. Now, when someone is thinking about suicide, oftentimes there's a lot of models for treatment that we might use to how we work with that person. I particularly like what's called the collaborative assessment and management of suicidality approach. Within this model, we actually look at what are called drivers of suicide risk. And we get talking to the person and begin looking at what is going on in that person's life, what in their social, their interpersonal, their psychological and emotional experience seems to be driving or influencing them to want to die by suicide. then we can use any number of things that might help us remediate those drivers, help them get a handle on those things. Now, alongside trying to help them with the issues that seem to be driving suicide risk, is we begin looking at actual safety. Right? So there's a lot of literature that says that when people are suicidal, right, when they're in crisis, one of the things that's going to predict whether they die or not is whether they have access to something that will kill them. In this country, it's hard not to get around the guns question. So guns don't make people suicidal, but suicidal people with guns become dead people. And when we're working with someone who is at risk, who is acutely at risk for suicide, oftentimes what we'll talk about what's called lethal means safety, where we'll think about, okay, you're thinking about suicide, and you actually have really strong urges for that, and you have guns at home. What can we do to make your environment safe? What can we do to get those guns out of the house, whether it's your friend down the street, whether it's a relative or someone else, or whether it's something as simple as changing the combination on the gun safe and not getting it back until after this crisis is over. It's about creating space between a person who's acutely at risk for suicide and something they might use to kill themselves. Now a lot of people, again, back to issues related to guns in this country, a lot of people have reservations about that. So sometimes we really have to think creatively and meet a person where they're at in an attempt to make their environment safe. And we have to be willing to have those conversations if we're going to keep people safe and save lives.
Okay. So, as Dr. Smith emphasized again, we know that the biggest proximal risk factor for suicide in people who have already passed the stage of hopelessness and intent and who have a plan is whether that plan is lethal enough to kill them. So Dr. Smith's research is actually focused on how to help people who have acute suicidal ideation and also have access to guns, how to help them be safer. Oops, okay. So this last slide, I just want to talk a little bit about what you can do if someone that you know is suicidal. This action plan comes from the CDC suicide prevention website, which is in the notes for this slide. So the most important thing that you can do for someone who you're concerned about is just ask, are you thinking about killing yourself? So that's a scary thing to ask. And one reason that someone might be hesitant to ask that question is, like, what if I give them the idea? Like, what if my asking that is the thing that pushes them over the edge? And I just want to reassure you that that is not going to happen. Asking someone about suicide does not make someone who isn't suicidal suddenly suicidal. But what it does do is it creates space between suicidal ideation and the possibility of a suicide attempt in someone who is suicidal. So when someone is suicidal, the next important thing to do is, as Dr. Smith does in his research and as therapists do in our clinical work, reduce their access to lethal means, whether that's some of the tips for gun safety that Dr. Smith talked about, or other means of suicide. So the other important thing, as important as friends and family and social connectedness are for suicide, and we know that because thwarted belongingness is a major precipitating factor, there's only so much that friends can do. So really an important thing to do is to help them connect to professional help, and an easy first step is the National Suicide Prevention Lifeline. The number is on this slide. Okay, so here are your takeaways for the third and final mood disorders lecture. So bipolar disorder, most simplistically, is the combination, not at the same time, but in the same person, of depression and mania or hypomania. Bipolar II disorder is a slightly less severe variant of bipolar disorder. Mania and hypomania are almost identical, but mania is more severe and intense. And the key difference between mania and hypomania is that mania is impairing. So as we talked about, there is actually a link between creativity and bipolar disorder. We don't know what drives that link, but one factor could be the hypomanic temperament. And that is really just the genetic tendency to mania, that some of the genetic risk factors for mania at low levels also seem to confer adaptive benefits, both in terms of personality, so having a lot of energy, having a lot of charisma, having a lot of self-confidence, and also potentially in terms of creativity. The way that unipolar and bipolar depression are related is that the depression is the same, but the risk for mania seems to be additional. On average, bipolar disorder is a more severe mental illness than unipolar depression, although in some individuals, unipolar depression can be quite severe. Really severe unipolar depression is rare. In that study I just read before the coronavirus pandemic, severe depression had a prevalence of less than 1% in the population. So suicide is linked to mental illness and particularly depression, but it's very hard to predict who with mental illness will go on to complete suicide because suicide is so rare. It's also important to remember that not everyone who attempts or completes suicide has a mental illness at the time. Intoxication, impulsivity, and really importantly, access to lethal means are also risk factors for suicide in someone who is not depressed. The interpersonal theory of suicide attempts to explain how suicidal intent and the desire to die develop, and how that desire to die can actually turn into suicide attempts and completion. So the link between intent and completion, in order for intent to lead to completion, there has to be capability. The strongest predictor of an imminent attempt, other than intent and capability, is access to lethal means. So really the key to suicide prevention is reducing access to lethal means. And that's because it's important too to treat the underlying mental illness and to work on some of the thoughts that lead someone to feel hopeless and to feel like they should die. So it is important to intervene on those thoughts, but the problem with just intervening on those thoughts is that it takes time and suicide can be a really fast action. So doing whatever we can to make it harder for someone to take their own life is the best way to prevent suicide. Okay, so there's your extra credit and further reading. And I will see you guys on Tuesday. Sorry that this lecture is a little bit long, but I'm trying to pack things in because we missed a week.